All right, so good morning. I'm Joe Iacono. I'm one of the ped surgeons at Akron Children's. You guys should see the first slide. I like to call this stuff horses, not zebras, because common things happen commonly. And we're just going to go through this. Usually this is interactive, so some of the slides I'll kind of gloss over because it's kind of hard to call on people when I can't see you guys, but we'll go here, okay? So the point of this is common things are common. And, everybody loves to talk about the esoteric, kid who showed up. And they always like to do that on the test questions and your absites, but you can't get the esoteric stuff. You don't know the common stuff, and common stuff happens. So, and the first thing I always say is that in ped surgery and in pediatrics in general, age and size are important. And an infant will have entirely a different diagnosis differential when confronted with the same constellation of symptoms and signs that a toddler would, that a 7-year-old would, that a 15-year-old would. And so see the patient, talk to the family. You get more information. You think everybody says, oh, we can't get any information out of kids. You get tons of information. And then make your assessment of what you're going to order based on your history and physical, because that's still the key. You can order a bunch of tests, and then some of them are going to be positive and be chasing. If you order the right tests, you'll get the answer much quicker and much more efficiently. So the most common scenario that comes up in test questions is this one, because it's a 4-year-old male presents to the emergency room with a 1-week history of progressive emesis. So right now I usually ask, what do you have to know? What do you want to know? Okay. And what are the concepts of what you have and want to know? Okay. So by history, we'll just go to it. By history, first question about vomiting is always, what color is it in kids? Okay. Is it clear? Is it food? Is it green? Okay. And green vomit is a completely different entity we'll get to later in the lecture, but green is usually, you got to worry. Okay. If it's not green, then when does the baby associate with feces? The timing. Does mom say, well, the kid eats and it comes right back up? That points to reflux. The kid eats, as soon as I put the diaper down, as soon as I put the burp bib down and, get the baby down, all of a sudden it vomits. So that means that the stomach is filling up and it's not reflux, but it's a little bit delayed. Or I feed the kid and a half hour later, the kid throws up. All different information. Okay. How many wet diapers? Is this a child who is everything is coming back up and you're getting dehydrated? Or is the question of some stuff's getting through, but you're just doing this? Is the baby happy? Does the baby seem satiated? Does it seem like, what's the most common thing when this happens? Usually is mom's overfeeding. Young mom, baby's crying, put a bottle in. Baby's still crying, put a bottle in. Overfilling, barf. They get worried. So then you get that history. So you also want to worry about fever. Fever in this baby gives a completely different differential diagnosis than no fever. Fever, you worry about a GI bug, you worry about COVID these days, you worry about something, but no fever, vomiting, a little bit of signs of dehydration, kid is constantly hungry, then you start worrying about some kind of obstruction. Physical exam, look for signs of dehydration, look for signs of tachycardia, lethargy, capillary refill is really important in kids because it works. Doesn't really work in adults as much, but in kids it works. Listen to them, read their exam. When you examine a baby's belly, when you put a hand on a baby's belly, they're always going to cry. You're cold, your hand's cold, you're not mom. Just put your hand on there and sit it there for a minute. Don't do an exam right away. I guarantee you it's always going to be tender unless you give them a chance. Then what are you going to look at? Okay. So this is the classic presentation of pyloric stenosis. Pyloric stenosis presents between 2 and 8 weeks of age, firstborn white males. And it is a complete gastric outlet obstruction. So in family medicine, I always try to look at the adult equivalent. There's an adult physiologic equivalent. That is that 45-year-old guy who comes in with an obstructed duodenal ulcer and is throwing up everything and throwing up all his acid, not keeping anything down. So you have a complete gastric outlet obstruction. So that causes alkalosis because you're throwing up all your acid. So you get a hypochloremic, hypokalemic metabolic alkalosis. You get paradoxical aciduria if you have a huge degree of dehydration, because what happens is as water follows sodium in the kidney, your body tries to conserve all the water, and there's a sodium potassium ATPase pump. As that gets worn out because you get a hypokalemic metabolic alkalosis, it changes to the sodium hydrogen ATPase pump, so you get aciduria. So that's another test question, and it just means anything for tests. So how do you get this? You can do a physical exam. There is some kids you can get a palpable olive, but these days you probably don't because these kids are presenting earlier. They're coming the year after a couple of vomits. The pediatricians are akin to it. You send kids in after a couple just look for an ultrasound. So if they're really lethargic and dehydrated and get a good abdominal exam, you can feel this thing. The gold standard is ultrasound. These numbers are not important because every hospital and radiology department will have their own normals. Classically, if it's greater than 14 millimeters and greater long and greater than 4 millimeters thick, we worry about pyloric stenosis. The better thing now is that a lot of places are doing a test feed. They're putting the ultrasound probe on, they're finding the pyloric channel, and they're giving a little Pediatric, and they're watching the Pediatric go through. Because if Pediatric goes through, then you might have a little spasm, you might have the GI bug, but it looks like waves going against the breaker. And so this, this vomiting with a thickened pyloric channel and no Pediatric going through the test feed is really the things we look for now. Upper GI is very good. If you can't do an ultrasound, you don't have a comfortable ultrasonographer and radiologist, nothing wrong with that. The downside to that is once you get a gastric outlet obstruction, you've got a stomach full of contrast, you want to suck it out because you don't want the kid to aspirate any contrast. So when do you want to operate? So here's the other physiologic thing that comes up, which is why they always love to give you questions on pyloric stenosis. Pyloric stenosis gives you this alkalosis. Think about it. How do you compensate for a metabolic alkalosis? And this happens slowly. It doesn't happen overnight, so it has time to do that. You always compensate the opposite. So you compensate a metabolic alkalosis with a respiratory acidosis. And a respiratory acidosis then means that what? Your PCO2 goes up, your drive to breathe goes down, and so you have to have your CO2 has to go higher to breathe because you're trying to get off some of that. You're trying to retain CO2 to buffer your system. Downside of that is babies, especially in the first couple months of life, have very susceptible to apnea, central apnea, which is based on their hypercapnia and their ability to breathe based on their CO2 levels. So if you have a baby who's got a metabolic alkalosis that has a compensated respiratory acidosis and you don't correct that, and you take them in the operating room and you put them under general anesthesia, they don't wake up. So you never want to take these kids to the OR until you correct their alkalosis. Just recently, a couple of years ago, somebody published, the question always is, how dehydrated are you? How many boluses do you need? Do we keep checking electrolytes? And poking these kids for labs was really bad. So someone actually did the test and said, if your chloride's less than 85, you want to give 320 per kilo fluid boluses, in a row, slowly, each over about an hour, and then re-equilibrate and check lights a couple hours later. If your lights aren't too bad, you just need one bolus. If your lights are in the middle, you just need two, as opposed to bolus, checking lights a couple hours later and re-bolus. And they said that, if your chloride's less than 85, that's how bad your degree alkalosis is. You want to give 3 boluses slowly so you don't, before you even poke them again. This way you don't waste time and waste labs and waste pokes on the kid. So when the chloride is greater than 85 and the bicarb is less than 30, it's safe to operate. So how do we do this? Maintenance fluid is D5 half now. This is a slide's wrong. Okay, this is actually brand new data. So now the ped surgery white paper just came out a month ago. We're now doing D5 normal saline with 20K, and that's a problem for residents who are ordering because this is usually not a fluid that is standard in the pharmacy. So D5 normal saline with 20 milliequivalents of KCl per liter is now what we're recommending, so we don't get them hypochloremic even worse. Okay. So boluses are normal saline. Most boluses today, we're talking about LR when we're talking about acidosis causing the need for boluses in trauma and sepsis. But this is one where you got a gastric outlet obstruction, so you're throwing up acids. This is the time where normal saline is your bolus of choice. So then you repair it with an operation. Okay. So the operation is done laparoscopically. Okay. It takes 3 incisions. There's a lot of papers out there doing this 1 incision. I don't do it 1 incision. I do it with 3. These 2 poke holes are 2.5 millimeters each, and a month later you can't see them. So I still say this is scarless repair. You put a camera in the belly button. You insufflate. You got to be real careful about it insufflating because they don't tolerate very high pressures. And then you hold the pyloric channel on one side, and you cut the first layer. And now we do it with a little bovie. And then you put another special spreader in and you spread the second layer. And so you look at this mucosa. So basically, because this is really thick and inflamed, that mucosal layer will actually separate from the muscular layer very easily. Okay. Complications, you can make it too narrow, you can make it too short, you can make it too long, you can make it too deep. So we do some testing in the operating room to make sure it's appropriate. We fill the stomach up, make sure we don't get any air out here, make sure air goes through, and then we bring the baby back. The thing we do is that we now learned over the years that we don't have to wait to feed these kids. Like anything else after surgery, I used to wait too long to feed them. They were in the hospital a couple of days. Now, once they're awake from anesthesia and they're crying, the best thing to give them is food. And they usually stay overnight because we're watching for some apnea from overnight from the anesthesia, but they stay. Okay? That's pyloric stenosis. Now, we have a 3-week-old girl. Okay, same age group. As you worry about pyloric stenosis, presenting with 1-day history of progressive emesis. So this is 1 day. Was doing fine until a day ago, then all of a sudden going okay. So you're called to the ER with a 14-hour history of emesis and dehydration. Babies usually don't get that dehydrated so horribly after 12 hours. So keep that in mind. You were signed out the baby has reflux. It's now midnight. 6 hours later, he has to reevaluate the patient before discharge. They gave a Pediatric bolus, and mom says that, the baby hasn't done well with the Pediatric. And, we figured, we're ready to go home, just have Pediatric go home. Well, now you look, and the exam was described as a benign exam. Now the baby's listless, lethargic, and heart rate is 190. Put him back on monitor. The vomitings continue with PO Pedialyte. Every time she's tried, she's vomiting, and you notice that mom's got a greenish stain. So now you got bilious vomiting and a sick kid. So again, assessment, sick or not sick. First kid is upset, not happy, dehydrated, but not tachycardic, not listless. This kiddo, you can poke 100 times and won't move. So what do you have to know? You have to know that this kid is sick. You have to have a sick, not sick switch. And the only way to develop a sick, not sick switch is see people. Don't see your computer, see the patient. Every time you see a patient, you develop your sick, not sick switch. All right. So this one's bilious vomiting, no fever. When's the baby associated with the feed? Almost immediately. No wet diapers, signs of dehydration, lethargy, cap refill. Now what do you want to do? Does this kid get an ultrasound? Maybe, and I'll say that in a second. But if you got bilious vomiting in a baby, you have to worry about this diagnosis, malrotation with midgut volvulus. You can't miss this. Any baby with true bilious vomiting, anywhere up to, it says 50% of children with symptoms present within the first month of life. 80% present in the first year of life. So in the first year of life, you got green vomit. You're going to be looking for malrotation with midgut volvulus almost every time. And the reason why you got to do this is because you have to rule it out. You can't miss it. And the adult equivalent of this is that older person comes to ER with pain out of proportion to physical exam, acidosis. They have an SMA thrombus. That has the SMA occluded by a thrombus. This has the SMA occluded by a twist. Same physiology. So initial findings are non-specific. They actually have a soft, flat abdomen because there's no air going through. They're not distended, okay? So what happens? The anatomy of malrotation is the following. You look at this, superior mesenteric artery has a distribution that feeds your entire small bowel. And then SMA distribution goes from the ligamentotrites all the way down to the ileocolix. And of course, it also does the middle colic, but that's a early branch and it's pretty thick and it's usually preserved even in malrotation. So the body has this really long, wide arborization of the SMA to give it as much backup as it can. When you have malrotation, these LADS bands, which are probably the white line of Tolt developing too soon, cause the duodenum not to be able to go underneath, slide under, and go up here, so it stays straight. So now your SMA comes off, you got a middle colic branch, but it comes straight down. So all the ileal branches, the junoileal branches, and middle colic branches are now off one pedicle. And this whole small bowel now is a heavy load, like a tomato on the end of a vine. And so what happens is when they're born, there's no air in there, so it's not heavy. But as this fills up with air and food, it gets heavy and it starts twisting. And because it's fixed, it always twists clockwise. So you have malrotation with midgut volvulus. Midgut means SMA. Foregut is celiac, midgut is SMA, hindgut is IMA. So now you want to get a stat upper GI. Anywhere you are, anywhere will do this. What you want to look for, if it's normal and you do your upper GI, this ligament of trites has to be to the left of the midline has to be above the pylorus and posterior to the pylorus. So you have to get a lateral film. That's why these are lateral films. You see, it comes up, it tries to come in, it just stops. Corkscrews. These are the LADS bands causing compression. This is a baby who has malrotation and thankfully hasn't volvulized yet. Okay, this kid's got bilious vomiting, and this one, it's open, but you still need the same operation to prevent a volvulus. So it's malrotation until you prove it otherwise. While you can, you get an IV. You're never going to hurt a kid with an IV. Okay, unless they have a cardiac diagnosis, you're never going to hurt a kid with an IV. Give them some normal saline or LR. Now I would say give them LR, okay, because they're acidotic. And you want to treat them with LADS procedure. So if you miss this, this is a baby from my fellowship that unfortunately went to an ER, outside ER 3 times in 4 days. By the time they got to us, the entire small bowel was dead. And this baby did not make it. So this is their entire small bowel, and that is not you got to resect it. They don't survive. So this is what happens when you find it early. This was a Christmas Eve baby a couple years ago. Baby came in, was 5 days old and had bilious vomiting. And I literally just given this lecture to the pediatric residents and they nailed it. So they got the upper GI, had malro, had a volvulus, and you take the kid to the OR and you look in this left upper panel. And that doesn't look too bad. It looks alive, but actually that's pretty ischemic for baby bowel. And here's the volvulus around, there's the twist. So now I untwisted it. Okay, starting to pink up. This is pinker here, but it's still kind of thing. And I got to release this band. I've released the blood supply. So I release this band. It's really thick and tenacious. I get it down and I start spreading. I find the appendix because the appendix is stuck in it. I take the appendix out here and I widen the mesentery. So I make this really wide. So this distance between here and here is now this distance when we're done. So you lied it, okay? So once again, talk about upper GI. This is what the last gate, you want it to the left of the midline, left or superior to the pylorus, and posterior, okay? Barium enema can suggest pyloric stenosis, but it can't. Ultrasound is showing a lot of good possibility to use. We're actually going to start a trial at Akron Children's of doing ultrasound first because now it shows SMA, SMV, and reversal, but also shows swirling of the SMA. So the swirling duplex of the SMA flow is diagnostic of malro with midgut volvulus, and we're doing a prospective trial to see if we can do that instead of upper GIs because it's quicker. So now you have the new baby. This too quick? You guys doing okay? Silence.
We're good. We're good here. Yeah, everything's fine.
Okay.
Thanks.
Now we have a 2-week-old male. This is in the newborn nursery, or your step-down nursery or your feeder grower. Kid comes in and says that, we have babies in respiratory distress. You ask for some history. Baby was doing okay, was on some nasal CPAP for a couple of days, had a little fever, had a rule out with some amp and gent, but doing fine. And now all of a sudden they get an x-ray because the kid's got a respiratory distress and you see this x-ray. So if you see this, I don't know if it projects well through the internet, but it looks like a tension pneumothorax. Big, wide, air, black area. There's another one here that's not tension yet. And you see that. So what happens is they'll say they want a chest tube. Be very careful in putting a chest tube in a baby that's had slowly progressive respiratory distress over days. Okay? So you go and assess this kid. Respiratory rate is, heart rate is a 220. That's a sick baby. Sats are 82%. Now they're on a positive pressure ventilator, and they say it seems to have gotten worse as being on positive pressure. So you got no breath sounds on the right. So the chest tube is at the bedside, and what do you want to do? The attending is 30 minutes away. They're trying. Or worse, you got to transfer this kid to Akron Children's because they're in your ER. So this is something called congenital lobar emphysema. This happens about once a year in this area where they're outside the hospital. It happens about 3 or 4 times a year in our NICU, and luckily they're kind of attuned to it, but here it can happen. So what it is progressive hyperexpansion of lobar lobes. It's not present at birth. It's usually associated with positive pressure therapy. And so what happens is you almost get like an asthmatic where the bronchiole will accept the air, but it won't come back. It's usually upper lobes. It's associated with poor cartilage development. chest x-ray appears to be a pneumothorax. So if you put a chest tube in this, you're actually evacuating that extra air, but you're actually putting the chest tube in the lung parenchyma. So what's going to happen is you're going to put the chest tube in, you're going to get a whole bunch of air out, you're going to think you're great. So that's going to go from 82 to 94, and then about 20 seconds later, it's going to drop to 70, because now you're ventilating the chest tube, not the lung. So if you have tension physiology true like this baby we're looking at, 82% on the ventilator, heart rate 220, blood pressure starting to tank, you got to evacuate that air. So you put that in, you evacuate the air, then clamp or put the chest tube on a water seal. Don't actively suck on it, and try and main stem intubate the other side. Just advance your endotracheal tube and try and just ventilate the other side. That will buy you time. Your SATs will get to about the mid 80s. You'll do okay. And you can transport or get the baby to the operating room, because the only treatment for this is operation. And this is what the lung looks like. It's hyper-aerated. It's never going to work. And you make an incision, and the thing just pops out like a zit because it wants to expand. And this is normal lung here. This is hyper-expanded cystic change lung. It's never going to work, and you just take that out. That's lobar emphysema. Next, a classic presentation is a 9-month-old. Boy presents the emergency room with severe cramping abdominal pain. Of all the diagnoses that you read in the textbook, this is the one that truly the majority of the time presents like it says in the textbook. Presents with a 12-hour history of lethargy, appears intermittent inconsolability. And the one thing I'll also say before we go on to this is that this is something that we think we're seeing more of because of COVID. Mother tells 2 bouts of emesis in dark-colored stools prior to arrival. Mom says that the baby will cry, pull legs to his chest, and then lays quietly sleeping and actually can't hardly be aroused in between these episodes. Everybody in the house has been sick. Mom and brother was sick, sister was sick, everybody was sick like about a week ago. So what do you want to know? You want to know this kid has got pain, curling up in pain, severe pain, and then intermittently has periods of quiet. Okay. What do you have to know? You have to know that what we just said, the history of fever, vomiting, diarrhea, wet diapers, all those things are normal. How dehydrated is this kid? Is the kid drinking? Is the kid vomiting? You got to look for the signs of dehydration. In this age group, you can still look for modeling. You can still look for tachycardia. You can still look for the baby, whether or not the child is going to respond to you. And this is one where you'll go in and assess the kid, and you'll say, oh, the kid's fine. The kid's sitting there. The kid's quiet. There's no problem. And then the nurse will come back and say, the kid's screaming at the top of their lungs. You're visiting another patient. By the time you get back, the kid's quiet again. You're like, I don't understand. This is why. So what do you want to do? This is the classic description of intussusception. Any child between the ages of 3 and 18 months, this can happen. It happens equally in male and females. It's this crampy, intermittent, inconsolable abdominal pain with periods of lethargy. The periods of lethargy are the fact that this happens in between the peristaltic wave, which happens about every 20 to 30 minutes, and that's when they get pain. And in between, they're lethargic because they have a bowel obstruction and their third spacing fluid, and they're getting dehydrated and getting acidotic. Their heme-positive stools, that classic current jelly stool, is a late finding because that happens when the bowel's been ischemic for so long that it's starting to slough its mucosa and you're bleeding. So if you have current jelly stool, that's a late finding, and you want to catch these before you have that. Again, the best test for this is ultrasound. Physical exam can show a mass, especially when they're in that lethargic period. You can feel there's usually a palpable mass when they're lethargic, and I felt this is the one where I felt it because it's usually so big. They usually have been sick, or somebody in the family's been sick. This is usually a post-infectious lymph node or lymphadenopathy of the mesentery that causes this. Plain X-rays can help you make the diagnosis, but they never rule it out. Okay, there's a couple, and just so you know, there's a couple papers out there that says that KUB can rule out the disease. And the downside to those papers is that the radiologists who write those papers never see the patient bedside and never take ownership if they miss one. So you can't miss it with just a plain film. You can get an ultrasound and you look for these targets. And I give you a picture of a CAT scan because it looks so pretty on a CT scan. So sometimes these kids will get CAT scans to rule out appendicitis, and you'll see this target sign. That's intussusception right there. You can see it on ultrasound. It's not as pretty. Once you have the diagnosis, you have it. So a lot of protocols, we protocolize everything. Everybody knows a pathway. Everybody knows what I'm supposed to do. And you'll say, okay, well, if I think I got intussusception, I need an ultrasound. Well, if somebody's already got a CT scan showing intussusception, you don't need an ultrasound. You've already proven it. But the thing says no. make the diagnosis. If you order something early, order ultrasound. The nice thing about ultrasound is you can say, give me an ultrasound for intussusception, ovarian pathology. If it's a girl, look for ovarian cyst, even in younger kids, or appendicitis. And so you want to look at all three of those. But if you don't ask them to look for intussusception, they're not going to put the probe in the midline. They're not going to go up in the right upper quadrant. They're just going to try and find the appendix. So that's what you want to do. Between this earlier age group where you're not thinking about appendicitis, think about intussusception. How do you fix this? Usually you can fix this in radiology with an enema. Okay, depends on when, it's all about timing. If it's an ileocolic intussusception, you get air or water soluble contrast and it can push it back. Okay, you can get intussusceptions anywhere in the GI tract. You can get small bowel intussusceptions. You can get ileocolic intussusceptions. The one that you have to fix is the ileocolic one, because once it's through the valve, it can't come back. Small bowel intussusceptions usually fix with just hydration, usually a sign of dehydration. And if you've ever had your personal, if you've ever been so dehydrated, you get that crampy abdominal pain that doubles you over, and then you feel better a couple hours later. That's probably a small bowel intussusception that you've dealt with yourself. If they're acidotic, if they've got free air on the plain film, if they have any signs that the bowel is dead, usually got to go right to the operating room. Okay, so this is some operating room pictures. This is what they look like. Okay, most of the time they're called idiopathic because we don't have a reason, but this is a Meckel's causing it. With appendicitis can cause it. So you have an anatomic lead point like a Meckel's that can make you more susceptible to it, and we worry about that if they have a recurrent intussusception. Here's where this one is still healthy. This is intussusception. That's a very uncommon one, but can happen. That's that dimpling afterwards. That's actually a lymphoma. But that's usually, I just put that in there, okay, for the residents. Now, if you reduce it, you can get an ischemic. So obviously, this bowel is dead here. This has to come out. And you have to do a resection, and usually you can put them back together in the same operation. That's intussusception. All right. So newborn. Now we're down to the babies. So you're just finished your 5th consult. It's 4 o'clock in the morning. You want to go to bed. You're almost done, and then you get a transfer from a newborn at home with a midwife and mild respiratory distress with excessive drooling, which became worse during attempted fever. They've had 3 episodes of DSATs, but no apnea in the ambulance. It seems like the DSATs only happen with feeds. EMT says the baby looks fine, but you're the peds hospital. So they don't think anything's wrong with the baby's fine. The baby's drooling a little bit, but otherwise looks fine. You get an x-ray. So there's a newborn with an OG tube that doesn't go past anywhere here. That's blocked. So you got an OG tube with blocked esophagus, but you got air in the stomach. How'd that happen? Okay. So you have a blocked esophagus, but you got somewhere that's getting air in the GI tract. Okay. So this is TEF, tracheoesophageal fistula with esophageal atresia. We see this most of the time in the NICU. This is one that doesn't show up. The type Cs don't show up on prenatal ultrasounds very often because the esophagus is so small and they don't have polyhydramnios because they're not obstructed distally because of the fistula. So sometimes this is something that we'll find serendipitously, and this is the one where I put it here because it can be delivered by a midwife at home. But it happens 1 in 3 to 5,000 births. If you ever ask the question about the incidence of some congenital anomaly, just say 1 in 5,000 births. That's what, most of them are guessing at. Sometimes we'll, like pyloric stenosis, we have a little more data, so we know that's 1 in 300, but something rare, if you're ever discussing it, just say that. Male and females are affected equally. You have to worry about VOCTRL, which is why I put on this thing. Every baby who has either a vertebral anomaly, an anal rectal malformation, a cardiac anomaly, a TE fistula, a renal anomaly, or a limb anomaly. If you have one of these, it's an isolated anomaly. If you have 2 or more, your baby is described as a VOCTRL syndrome kid. VOCTRL is not associated with any chromosome, any anomaly. It's just an association. All these things kind of develop around the same point gestation, which is around between 9 and 14 weeks. And something happens in the blueprint at that time. And so if something happens, 1 or more of these things can happen. There are 5 types. Type Type C is the one that, you guys are mostly, type C is the most common, 85%. So C is common. It's a proximal esophageal atresia with a distal fistula. So this is what the thing looks like. You got a pouch and you got the distal esophagus attached to the trachea. So when they're breathing, they get air down and so their stomach fills up with air. Okay. So this one you can imagine is a problem because what happened is that they throw up, they can vomit acid directly in they can aspirate acid. So that's what you have to worry about. Okay. And if you try and feed them, usually they'll barf. Okay. This pouch will fill and barf. They usually don't get, they don't aspirate unless you try and overfeed unless you get aggressive. The other ones that, a pure esophageal atresia where you have a proximal, the thing that would look like on this, you'd have this x-ray, but the stomach would be empty. Okay. And then that we get type A. And the other one I'd like to ask you with is the type E or the H-type fistula. This is the one where you get a kid who comes in with recurrent pneumonias and the 2 or 3 pneumonias in the first year of life that you can't explain. That's their debt, and that is where they have a connection between the trachea and the esophagus. The reason why it doesn't happen all the time and why it's intermittently is this diagram is not right. Usually it goes up, so usually you don't aspirate unless you reflux. So if the kid doesn't have bad reflux, they don't aspirate a lot, but most kids will reflux, and then they'll come in with intermittent pneumonias, and you get an upper GI, and you diagnose it that way. So you treat it surgically. You can do it open or laparoscopic. You identify the vein because the vein is where the fistula is. Usually ligate the vein and find the fistula. You ligate the fistula, and then you try and do a primary anastomosis. Okay. You can do this. Again, we're doing more and more of these things with the scope. One of the things about the scope is it's hard because you're only ventilating one lung, and until you get that fistula ligated, the air is preferentially going through the GI tract. So you're limited until you get that fistula ligated. Then once you get the fistula ligated, you usually take your time and put the 2 ends back together again. One thing for family docs that is coming up with this is if you have a baby who's had a history of TEF or PEAR, the new recommendations are that we actually want to see these kids back at a year now, and we want to scope them and want to biopsy them. We also want to see them at age 6 and at age 13 because there is now, as they're studying these things, there is an incidence. It's small, but it's real enough to monitor these kids of Barrett's because they do have increased reflux. So we keep these kids on a PPI for at least 12 to 18 months. And then we try and wean it if they can, if they're not symptomatic from the reflux. But then we also do endoscopy surveillance. So either us or the GI med docs can do that. Now, this is the most common thing you'll see. You see it probably 3 or 4 times a week. 7-year-old comes in the ED with a 12-hour history of abdominal pain that they say is in the right lower quadrant. I find that I'm told it's in the right lower quadrant, even if it's not in the right lower quadrant. So just my own bias. The mother states that they'll have 2 bouts of emesis. They haven't eaten today. They feel warm to mom and vomit in the car. No balance for a couple of days. Supposedly felt well this morning. So again, the classic diagnosis of, you got to worry about one most common thing we see. What do you have to know? What do you want to know? How long has been going on? We talked about 12 hours. What symptom was first? I actually am a fan of if they're vomiting with pain, I'm a fan of finding out if the pain happened first or if the vomiting happened first. Do they have diarrhea associated with it? Did the diarrhea happen late or did the diarrhea happen at the beginning? Because dehydration can mimic this all the time. Vitals are important. Okay, how dehydrated are they? Kids have good vital sign response to dehydration. Okay, what's their blood pressure? What's their mean arterial pressure? What's their heart rate? How they, are they having a fever? Again, even in the older kid, when you examine a kid's belly, especially if you're the 3rd or 4th person in there to examine them, you're going to go after the belly. They're going to flinch. They're going to guard. They're going to do this because they're scared. Put your hand on their belly and talk to them. That's when I get a social history. Like I start an exam and I get their social history. So where do you go to school? Try and distract them. What's your favorite thing? What's your favorite TV show? Talk to them and just put my hand on their belly. Okay. Then I start to slowly go around. You never have to press more than a centimeter or 2 to evoke real surgical pain. Okay. If you're pressing the belly, if you're pressing to the bed, you're inducing pain. Okay. You're inducing tenderness. So your goal of abdominal pain every time is you want to recognize signs and symptoms of surgical abdominal pain versus non-surgical pain. You want to identify labs and radiology studies, and you want to determine the timing of the surgical consult, which is always wrong if you talk to the surgeons. Okay. So when you talk about ABCs, just talk about it last slide, but C does not scan for CT scan and S is not ultrasound immediately. Okay. You want to get some data. Okay. So there's the stats. The majority of pain, abdominal pain in kids do not have surgical conditions. And so this is a comment I always make to parents when they come in and their kid actually has a perforated appendix, and then they got the parent guilt. Well, I should have brought them in the day before. I should have brought them in 12 hours before. I said, guys, if you brought your kid to the ER every time they had belly pain, you'd be there every day. Okay. All right. And I am a fan of that. The acute abdomen is sometimes difficult to diagnose. You know, it sometimes presents late in the course, but the later it presents in the normal pathophysiology, the easier it is to diagnose. Okay. Surgical pain is usually not subtle if you just take the time and talk to patients. Okay. So here's some clues. Okay. Examine your patients and then examine them again. Second exam cannot be emphasized more than just examine them again. Okay. And pain and tenderness are not the same. So if they're say they have pain in the left lower quadrant, but you feel them and they're tender in the right lower quadrant, say that. Okay. Don't assume, don't talk yourself into, well, they're saying there's pain here, there must be tenderness there. Sometimes you have referred pain, especially in girls, especially in that 12-year-old girl who's got the right ovarian cyst that's pressing against her left kidney. The referred pain is different. Okay. And just like adults, you got to be aware of any kid with a previous abdominal surgery, including G-tubes. We've seen adhesive small bowel obstructions from just a G-tube operation. Steroid use, neurologically challenged children, NICU grads, especially preemies. Any kid with cystic fibrosis, they have their own diagnostics, differential diagnosis tree, sickle cell disease. And then always worry about really nice parents from a medical family because they're going to have the zebras. So we talked about the first slide. You have an age-dependent differential diagnosis for surgical pain. So infants, you got to worry about malrotation, newborn first month of life. Toddlers, intussusception. Older children, appendicitis. All children, you got to worry about trauma now. You got to worry about non-accidental trauma. But these are the top surgical diagnoses depending on age. So a toddler can have appendicitis. They can have a perforated appendicitis. A 7-year-old can have an intussusception. But the more common thing is by age. Kids stop performing fun things. So when I walk into a room in the ER and I see a kid watching the latest video on the phone, on mom's phone, with cross their legs with their hands up and they're distracted when I walk in, I'm not too worried about rushing that kid to the OR. They may need an operation, but they ain't gonna need an operation in the next hour. Look at your kid. If you walk in and the kid is doubled over in a fetal position and doesn't want to move and is not interested in what mom's sharing her phone for the first time in a week, that kid's sick. Okay. Kids who usually want to eat and don't. Okay. A usually easily consolable child is no longer comforted. Pain awakens child from sleep and pain radiates in a normal pattern. Okay. All those things make me worry. Okay. So we said signs of surgical problems on exam: immobility, localized tenderness, involuntary Gardner rigidity. You don't have to press hard. You really don't. Pain continues to worsen, and pain worsens or localized by dehydration. The majority of children who come to your ER with abdominal pain are dehydrated, period. That's what they are. Okay. Now the question is their belly pain due to dehydration, or is their belly pain due to something surgical that's making their dehydration worse? Okay. So if you got really bad distension, you got previous scars, the kid was asleep and you just go in there and you really touch the bed, and the bed, touching the bed makes them wake up. If they have redness in their belly wall, I worry about that. Okay. As I said before, testing for rebound rarely helps, and rectal exams are not really indicated unless you get a KUB that shows that they're really full of it and you're really worried that constipation is causing this. Okay. Teenagers have their own issues. You got to worry about pelvic exams. In most women of child, you at least think about it and make sure you get a good history. Make sure you get a history where someone in the room which they're comfortable with by themselves. Okay. Teenage males, you got to always look for a hernia because especially athletes, they're lifting, they're not telling you, and they have an incarcerated hernia. If you don't take a look, you're going to miss it. Okay. So labs should be focused and limited. Okay. But you also want to avoid multiple sticks. So sometimes we'll draw labs, but not send them all. CBC and UA usually indicated, and you need an HCG. LFTs, coags, amyloids usually rarely indicated in the first play around, okay? The radiology studies, if you order enough radiology studies, you're going to get positive answers, even though it won't make sense because you're ordering the wrong study, okay? So plain x-rays, if you're worried about a kid who's got more than a couple days of pain and it's not looking sick, maybe you're worried about constipation, maybe you're worried about something else, that's a plain film, okay? They can be a nice screening test for intussusception, free air, or kids with previous surgeries. And also sometimes they have pain in the right lower quadrant, but they don't have any tenderness in the right lower quadrant. Sometimes that's a pneumonia, okay? All right. Ultrasound. Everybody loves ultrasound. It's become ubiquitous. And the question we can talk about for hours is, do we do ultrasounds ourselves? Do we do point of care ultrasounds? Do we get radiology to do it? I'm of the generation that still says a radiologist does a better ultrasound because that's what they do for a living. I am not, I did not get taught in it. I'm learning ultrasound, so I try and do ultrasounds myself to try and get better, but I will not use my examination over a radiologist examination, okay? You guys are going to get better with that, and you're going to do it in your office, and you're going to get very, very happy with it, and that's going to be different. That's going to be where you're going to be better, okay? When it's positive, you want to do it, but you also want to let the tech know where you want them to look. Okay. So if you tell, them, if a 7-year-old sounds like they have intussusception, even though it's not the most common thing, you're going to say, listen, I want to look for intussusception, even though it's a 7-year-old, because a tech's going to see abdominal ultrasound 7-year-old going to be looking for the appendix and see that they're done. Okay. You got to write the right things. Okay. CAT scan, very, very sensitive and specific. Okay. It's readable by non-radiologists. Okay. I'll tell the surgery residents at Akron that, 2:00 in the morning, they have to be able to read that x-ray and that ultrasound and that CAT scan as good as anybody else. Cause sometimes we have a radiologist who's not in our building, who's, doing a read from Cleveland. Okay. So they got to be able to do this. Okay. IV contrast is what we do. We're looking for belly pain. GI contrast does give you better sensitivity, but most of the time it doesn't get where it needs to go. So usually IV contrast only. Stranding is what you're looking for. You're looking for localized stranding, because localized stranding is IV contrast that sticks around in the venous phase, it brightens up, and that's a sign of inflammation, okay? Non-contrast CT scan, no contrast CT scans are only 50% sensitive for appendicitis unless they do some other machinations or thin cuts or radiology, there's sometimes they do that, but so if you get a non-contrast CT scan, it's negative, it really doesn't help you, because you got to still worry about it. Radiation exposure issues are real, and that's why we try and not do CT scans as our primary. So to me, I would like, if you get this and you get a child this, examine the child. You think they're dehydrated, they're tachycardic, they don't feel good, put an IV in them, get a CBC and a UA, give them a couple 20 per kilo fluid boluses. Why? There's a couple reasons for that. Number one, you re-examine them after that, and their pain's going to change. Either if it's pain's caused by dehydration, it's going to be fixed. If their pain's caused by something surgical, especially appendicitis, it's going to start to localize, because you're going to make whatever's inflamed more swollen. And 3, if you get an ultrasound after that, now they're better hydrated, and the ultrasonographer's got something to look for if that appendicitis is more plump. Okay, so the re-examine gives you a lot of information. Okay, points on the curve, and that's one of the things that I like to teach. All right. And what you'll see is kids will, we did not have very good ultrasonography at where I worked last. And so our rule was, kid came in with belly pain, we were worried about surgery, we'd give them 220 per kilo of fluid boluses, we'd order the ultrasound, and we'd re-examine. 50% of those kids would never need an ultrasound because they're ready to go home. 25% were getting ultrasound, 25% were we had a clinical diagnosis of appendicitis. Now we get ultrasounds, everybody to confirm it. And part of that is because we have really good care here, but we like to get them hydrated. So when do you call surgery? Okay. You want to call surgery when you won't get yelled at. Okay. But you call too soon, you're dumb. You call too late, you killed the patient. Well, what do you do? And the other thing is, I don't know why, but belly pain never happens before 9:00 at night. It just doesn't. All right. Surgical, it just doesn't. Because, I think part of that with kids is that parents get up, kids not feeling well, go to school because they have to go to work, and then they come home and they try and get into the quick care at night, and then by the time they get there, they get sent to the ER about 7:00 at night. It's shift change, and by the time the workup's done, it's 9:30 at night, and they've been sick all day. So you want to be able to get that, okay? And this is my favorite. When I always say the ER, it was like you know, I don't know who the bunny is and who the donkey is, but usually the donkey's usually the smart ass surgeon. So you want to get a careful history and physical. You want a differential based on age, timing, location of pain. You want to do it yourself. Do it yourself twice. You'll be happy when you do it. You want to get a CBC and EUA. You want to get a 20 per kilo fluid bolus. You want to re-examine. Okay. You want to get better pain. Observe that should be observer ultrasound or some kind of imaging and localized pain with peritonitis. You have your answer. I think we're going to stop there. It's 10:45. I think this was 45 minutes, right?
Yes.
Yeah. Yes.
Questions?
Question?
There are no questions in Youngstown.
I don't think we have questions, no. That was really helpful. I wonder if you could send the your slide, your PowerPoint maybe to Dr. Miller or to Lori, and then she can get it on to us. That would be awesome.
Yeah, and the PowerPoint's bigger. It's got yeah, I can send you this PowerPoint. Yeah, absolutely.
If you don't mind.
No, not at all.
Yeah, because the cases are really great. We could use those.
Yeah,
So
and now if you guys want, there's I'm happy to talk about whatever you want. I'll tell you, I have canned talks on newborn bilious vomiting, trauma, what else? I got a lot of them, you know, and then individual ones that I do for I did actually I should have invited you guys. I do a ABSITE review for all the surgical residents in Northeast Ohio every year. I just did that in January. I do that up in, actually that's up on YouTube. So if you want to cover every ped surgery topic there is, and it's a little bit more akin to a surgical residency, but if you look at J.I. Akono on YouTube, you'll find that. It's a 2-hour lecture.
Cool. Awesome. Thank you very much.
Yeah, I'll send this over. Okay.
All right.
Yeah,
Thank you. All
That would
right.
be great.
All right. And Laura, we're going to sign back into Zoom, correct?
Yes.
All right. I'll see you on Zoom then.
Thank you.
Thank you
Dr.
very much.
Arcano.
We'll see ya.
Bye.
Bye, Lori.